exemption for a time. But you don't know Muhammad, because he might jump in the meeting and saying that please switch off the meeting and we need to switch to another. So let us start with our pioneer, Professor Rohit Shetty. Well, he is giving one lecture in a diagnostic technology in refractive surgery, that he will start with the patient selection. And I respect a lot my dearest friend, Professor Rohit, in his way and his approach to select the patient. So let us see how he will select the patient for a refractive surgery. Please, Dr. Rohit.
Thank you. Can you hear me? Am I audible?
Yes.
Yes.
So thank you. Thank you. Just a
I
minute.
think that we can make all mute. Yeah, for the all, let them be mute in a way that we can listen to Professor Rohit in a clear way. Thank you very much for all. Yes, Professor Rohit.
Thank you, sir. Thank you, all the members of the society, for giving me this chance to speak about the patient selection in refractive surgery. And these are my financial interests. I do research for many of these companies, and I'm sure that this does not come in the way of what I'm going to discuss today. So when you're looking at a refractive surgery patients, I mean, these things have been discussed multiple times, so I'm not going to dwell too much into this. It's about your age, the stable refraction, myopias. I mean, there are a lot of debates on how much you can go to, but companies have really put in the criteria of to around 12. People have done it in the past. Now, probably with the ICL, we will not probably do it. And hyperopia changes. What history is important today is the family history of keratoconus. It's a very important history, which in the earlier time we would never ask. It is very important. Eye rubbing. There are people who are used to eye rubbing. People who have systemic allergy. Contact lens intolerance is very important. I'll come to why it is important. History of keloids, systemic disease, and this is something which we normally don't ask, or we don't do it. We are getting more indoors. One of the major factors I've seen a lot of my patients today is people are having, because of COVID, a lot of people are indoors, they're not exposed to sunlight, and there are a lot of vitamin D deficiency and a lot of changes in their diet pattern also. So let me start with the basic dry eye evaluation. There are a lot of algorithmic approach about the staining, and what do you do? And you can get it from the ACRS websites about the ocular surface disease algorithm. So when you can choose any kind of algorithm you want, but this is something which is good. And it helps to look for the outliers. And then we look at what is really, what are the ones which you need to avoid. The basic ones which we look at is your slit lamp. Look for the meibomian glands. The OSDI is very important. I use the OSDI scoring. The Schirmer's T-bath and staining is very important because it tells us the state of ocular surface. And advanced diagnostics like meibography, LipiFlow, and now you have the OCAS, or the optical quality system, which looks at your tear film. And this is important. I already mentioned, we can also have, if your ocular surface is poor, if your T-butt is lower, then you can consider staining to see if there's any issue, which especially a contact lens intolerant patients. And like I said, this is one of my gold standards that, especially we need to know how the impact of ocular surface is. And this gives us a good insight into the patient's ocular surface. There are different meibographers today, which looks at the healthy meibography. You can have a 10% loss, 20% loss, and you can see that there is more than 60% and then 80% loss. So these are all very important to look for, because these are the patients who will be very unhappy, and different grading systems has been mentioned. For a stronger refractive practice, you can also have looking at the tear film. LipiView is one of the very good ones, which looks at the entire lipid status of your eye. And if you have access to it, it's a great one, but it's not that you need to buy it or only for your refractive surgery practice. This is what I said is very interesting, is looking at the optical quality of your tear film. Optical quality of a tear film is very important because my talk today is not mix of only traditional ways. I'm also trying to mix traditional, modern, and the future, all of them, because this will give an insight to everything what the people want. So, for example, this is an optical quality of a tear film from the start of the first blink to the time the patient blinks again. So it is maybe in 10 to 12 seconds. This is what happens to your optical quality. And this is a patient with dry eye. And you can see that the optical quality drops in that 5 to 10 seconds. So that means that if this patient is coming to you for LASIK surgery, this person will be terribly unhappy because this is his quality of vision and this is going to get worse. And because his quality of vision is get worse, the tear film actually drops, becomes worse. And this is the major cause of being unhappy. At the 6th second itself, the vision drops because of his tear film. And this is a very important point we need to understand as we move. These kind of tools are today for more for research, but I'm sure at some point of time they will become part and parcel of your practice. We did a lot of work on vitamin D, B12. I believe that this is one of the major factors. It does not matter whether you may be in Middle East or India, or you were living in Norway. These factors are people, if you're indoors, even if you're living in a desert, you will still suffer from deficiencies. And this is very important. And I also believe a patient with asthma or allergic tendencies with high IgE levels have a lot of issues with irritation, and they are the one of your eye rubbers, which may lead to problems. Epithelium and nerves are one of the most important factors. Unfortunately, we don't have a mechanism to look at epithelium and nerves at this point of time. But just because we don't have it today does not mean that it's never going to happen tomorrow. That's what I said. My talk today is a mix of the past, present, and the future, mix of everything so that we have a clear idea. Why do you think the epithelium and nerves is important? It's because it's like this. If you look at the epithelial maps, we have different types of maps. We have maps like this and like this. These are all patients who come to you for refractive surgery. Now, let's see what happens if I go and check their corneal nerves. Why it is important is epithelium and nerves are connected to each other. A healthy epithelium has a healthy nerves. An unhealthy epithelium has unhealthy nerves. So they are all hand in glove. For example, this is good nerves. You can see that the nerves are structurally damaged and here is poor. Now let's see that if you do a surgery on them, let's say LASIK surgery on them, what happens is your epithelial healing is terribly bad. Now, I did mention in the beginning that these patients, you cannot do, everybody does not have access to confocal microscopy. So what do we do? For example, if I go back to the slides again, you can see that the OSDI is still the gold standard because a healthy OSDI means healthy nerves. And as the health of your OSDI increases, your corneal nerves changes. So it's a poor man's confocal microscopy. So that means your optical quality, optical disease score is a poor man's thing because with just doing nothing, you're able to, with just spending anything, you're able to get the insight into the corneal nerves. And this is something which we published a few years back. So what we are trying to say is very important to understand how the nerves behave. Let's go to the Barrons. The question which is asked is, in today's we're getting OCTs which are able to look at the Barrons layer. Most OCTs do have a resolution to look at it. Why is it important? It's because we decide sometimes on refractive surgery, like we do a smile, and you can see that sometimes the Barrons have wrinkles, and you can see that these wrinkles have an impact on your quality of vision. For example, these wrinkles actually changes your quality of vision. So that's a reason understanding the Barrons both in pre and post refractive surgery is very important, because this is one of those layers which is, I call it as a phantoms of your vision, because you can't hardly see it, so you completely miss it. And the new technologies like MS39 now, it brings you the concept about the epithelial thickness. Just the stroma, it virtually subtracts the epithelium, is going to change the way we look at it. For example, this patient, you would consider them as a suspect of keratoconus. But if you look at it from a pentacam, but if you look at it, It is not a suspect. It is just that his epithelium is thick out here and his stroma is completely normal. So that means that he's not a suspect. So that your definition of suspect is going to change with new technologies. Your definition of what you call it from frusts is going to be changed. For example, if this is not a from frust keratoconus, but if you have a same one technology, you will consider this as a from frust. So you have to be change with the time. Your selection of a patient has to change with the time. And these are all the new generation biomechanical assessment of the cornea. I mean, I'm sure we're going to listen to some brilliant lectures of indices. I'm going to skip this. And the most important thing is the way the biomechanics. Again, this is going to be discussed about how biomechanics is very important. There are different methods to look at it. So I'm not going to spend time on this because this is again going to be discussed. But what is new is a lot of new indices have come in, which tells you if your patient's cornea is strong or weak. Then comes your aberrations. Ultimately, the aberrations are the ones which helps you to understand from every aspect of it. I would like to start with the epithelial aberrations, the corneal aberrations, your lenticular aberrations, virtually everything. Why is aberrations important? Is when you look at a cornea, you look at a curvature, you have an astigmatism, and this is what you treat with glasses. But when you have a cornea which is filled with aberrations like coma, you cannot treat it with glasses. So why do you need to do the aberrometries, both from a corneal and the thing is you decide whether you want to treat a customized treatment or you want to do an wavefront optimized treatment. It's very important because if you don't know this and if you treat everybody the same way, then what happens is you patient will end up very unhappy because you have not taken care of aberrations. So understanding aberrometry is very important. And the same patient, if you do it, his quality of night vision is be terrible with this kind of a picture. And because you have designed that both the patient get the same treatment. If you do the same treatment of wavefront optimized treatment instead of a topo guided treatment. So you have to be very clear in the patient selection what kind of a cornea you have. We have brilliant ways of looking at the aberrometry. You can look at the epithelial aberrometries, Zernicase of the epithelium, the total corneal, the anterior, the posterior aberrometry, the ocular, and you can even look at the lenticular aberration. So it's a wonderful time to be in refractive surgery today. Virtually every layer, even the epithelial layer, you can actually pick up the aberration changes. And this is a classic example of I did aberrometry on a patient of a normal accommodation. This is a pseudo accommodation out here. You can see the red out here. It means that the patient is accommodating more than necessary. And these are the patients who complain of glare. And this guy is accommodating in a different way. You can see that this part of it is accommodating, this part is not. And this is full of green, means it's accommodating well. So you understand the aberrometers, you understand the way the patient is accommodating, and this helps in a big way when you're planning for the surgeries. This is important because when you're treating a patient who is now close to 35, 38 years, your lenticular aberrations have already set in. And lenticular aberrations, now iTrace gives you something called as a DLI, dysfunctional lens index, where you're looking at an aberrations of the lens. If you do a LASIK on him, this is just maybe a 42-year-old male or female, and if you do a LASIK on him, he's going to be terribly unhappy because his problem is in the lens. We call it as a dysfunctional lens index or a syndrome, and this is what your lens needs to be operated in it because it behaves like a cataract, does not look like a cataract, and that is where the changes are. The pupil is very important, and the size of the pupil has to be looked at always. And you'll have to look at what size of pupil you are doing. Why is pupil important? Is as the pupil size increases, you can see the aberration increases. So you have to be very careful, especially in a patient who has a high aberrometry. The pupil size makes the pupil. When the pupil is smaller, you have one image out here. As the pupil becomes 6 millimeters or longer, you have two images here. So it classically explains, even in a healthy person, how the pupil plays a very important role. And this has to be factored in when you're doing your surgery. And orthopedic evaluation is one of my favorite ones because most of my unhappy patients come because they are binocularly not stable. Their vision is not stable because there is convergence excess. There's accommodation excess, fusional versions, dysfunctions. I have to take care of it, especially if you're treating a lower myopia. If you're treating a patient who's had a mild orthoptics issues, headaches, or sometimes they masquerade as high internal aberration or they pseudo accommodate. So this is all important, and we can't treat them with just homide. They need exercises, and you need to be aware that binocular single vision is a very important factor for a healthy refractive outcome. And having a good orthoptics evaluation by you or your optometrist is very important. And this is something which we do, and this can be good got anywhere. This is a kind of flow chart we do. It's quite complex for this, but what I'm trying to say is we have to evaluate them, and that's a part of it. So how do we customize this? When you decide on the patient, is you can look at things like contura, where you're inducing less of aberrations, and these are all the values which we got during our work. It increases the depth of focus. Some published work on it, and there are machines which gives you trans-PRK. You can decide on it. Of course, this will be discussed about how both are different. I'm speaking on the third day on this about how machines differ in the way the profiling is done. You can choose the presbyopic platforms. There are Presbybond, the Presbymax, Supracor for the patient who wants it. Like I said, but the most important test is the blur tolerance test, where you're trying to tolerate how much the patient can tolerate to a particular blur induced by the eye, which you're trying to make him a little bit more myopic. But most important thing to be tested in all the presbyopia patient is your lens densitometry, the PNS grading, and the DLI. If the DLI is high, the presbyopic laser surgery does not work, because the lens does not just give you that effect what is necessary. So DLI has to be normal, and blur test has to be done. These are the two main prerequisites for a patient selection. And most important thing is what we know is that just because we have all aberrations, treating all aberrations, I think is a overkill. I think that is a wrong thing to do, because many times you just kill all aberrations. It is like killing all the commensals in your ocular surface. So what we have understood now is this is something which we are working on. This is the future, is using adaptive optics aberrometers. Now our aberrometers are very one-sided. They don't tell you which aberration we should correct and which we should not. The future is going to be, I've been trying to work, this is an adaptive optics aberrometer. It's like a phoropter, which tells you which aberration the patient would like to keep and which one does not. So I don't treat the entire aberration. I choose what he wants and what he does not want. And at this point of time, Schwind is the only one which gives me that capacity, and we are probably getting very good results. What are the futures? Few slides on it. I think we need to build new tools, new topographers, new tomographers to understand these kind of corneas. We don't know whether they are biomechanically strong, weak. So what do we do with them? Because at this point of time, none of the machines really tell us. So what we did was we did bid with a group from Vienna. We did build our own polarization sensitive OCT, which looks at the collagen imaging. These are how the collagen imagings are. This is your peripheral fibers. This is your central fibers. And we started looking at different corneas, and you can see that this is what I'm saying is the future. It's not something, but it tells you a completely different dimension. You can see that if it's normal collagen, you do your normal surgeries. If the collagen is poor, then you can think of an ICL. If the collagen, you can see that this collagen is lost. And in this case, the entire area, the collagen is not imaged at all. That means that these corneas are not suitable for anything. And now, of course, you can try your ICL or something, but this is how it would probably change. We need to look at molecular factors. I did work on different molecular factors, genetic factors in keratoconus and post-LASIK ectasias. And if not for COVID, we would have had demonstration of a real kit. This is the point of care kit, where you can, it's a reader, and you can see that when you read it, it gets your value. When you put it in this machine, it tells you a different molecular pathways markers, including some collagen and lysyl oxidase markers, which helps us to see what is happening.
I think that, Professor Rahit, we need to summarize, because we are exceeding and took all the 15 minutes that's given by
Okay.
Dr. Muhammad. So if you don't mind, just summarize
I will just summarize with one slide. The future, what I slide is, this is a paper we published looking at deformation of different corneas by mathematical modeling. What we have done is, this is my last slide. We have put all this into a software where you enter your biomechanics and your corneal prediction, and it will tell you which of your surgeries would induce what kind of biomechanical changes. And this is something which will be going to come out very shortly. To summarize, it's imaging, customization, and the future is AI and molecular prediction. Thank you.
Most welcome. Great, thanks, Dr. Professor Raheel. It was a comprehensive, thoroughly lecture for patient selection. Great, thanks for you. Now we have a second pioneer, Professor Mazen Sinjab, my close friends, and he will talk about the our subject, the diagnostic technique in refractive surgery. And I was wondering how he will summarize this corneal topography, but he's the most eminent lecturer and surgeons that he's better than a lot of better than me that in presenting and summarizing all the information in this lecture. So Dr. Mazen, please.
Yeah. Assalamu alaikum. Hello, everybody. Can you see my screen?
Yes.
Yes, sir.
Okay,
Very
great.
clear. You are, yeah, enlarge it only.
Yeah. Thank you, Dr. Safwan, for this nice introduction. And thank you, Professor Rohit, for the amazing lecture. I always find it difficult to talk after you. Thank you, Dr. Al-Amri, as well, for this Congress. As Dr. Safwan said, it's impossible to talk about tomography in 20 minutes or even 20 hours.
Yeah.
Actually, before I start, I'd like to tell you that I am one of the establisher of the Diploma of Refractive Surgery in Al-Hassan Al-Thani University in Casablanca, and I usually talk about tomography 1 day and a half. So almost 12 hours about tomography in brief, not in detail. However, I would like to invite everybody who is interested in tomography to follow my YouTube channel, Sinjab Academy. Just click on the playlist and then you can choose whatever you like. There are a lot of videos about tomography. So what I'm going to talk about today is the applications of the corneal tomography in laser-based refractive surgery, lens-based refractive surgery, and cataract surgery. Actually, the corneal tomography is very important to evaluate ocular surface, tear film and epithelium, to exclude risk factors, to study the astigmatism, to highlight the role of the angle kappa, to measure white-wide diameter, and to take into consideration pupil size and shift of the pupil, in addition to corneal wavefront. So for the ocular surface, of course, measuring the non-invasive tear film breakup time is very important, as Dr. Rohit mentioned, because whenever the tear film breakup time is abnormal, then this will affect not only the laser-based refractive surgery, but as well the results of the premium lens implantation in both lens-based refractive surgery and modern cataract surgery. Why is that? Because the dry eye affects visual acuity. It affects the K readings, the accuracy of K readings as well. It causes corneal irregularities and it induces high-order aberrations. This is an example of the irregularity induced by the dry eye. In addition, this is a corneal thickening in the center of the cornea, the epithelial thickening because of the dry eye. And this is an induction of high order aberrations. The RMS is 1, which is very, very high, and that's only because of the dry eye. It's very important to measure the tear film breakup time before putting any drops. Look at this tear film. It became abnormal after dilatation of the pupil. Second, we come to the epithelium studying because the epithelium has two roles, the masking property and the eroding limits. These should be put in mind when we check the epithelium. The masking characteristics, we all know that it has a filling effect in order to regularize the anterior surface of the cornea. This is an example of that. You can see that just above the intracorneal rings, how thick the epithelium is. This is an example of post-myopic thickening of the epithelium in the center of the cornea. If you look at the bottom left picture, and this is one of the causes of the regression after the myopic treatment. The eroding limits, whenever the epithelium over a peak becomes less than 25 microns, it starts erosion. So in addition, the epithelium is very important in early detection of keratoconus. As Dr. Rohit, now the keratoconus suspect term is being changed because of the new concept of the epithelium. This is a case of focal thinning of the epithelium. If you look at the picture on the bottom left, you can see focal epithelium, focal thinning over a hotspot, which is consistent with keratoconus. This is a normal steep cornea. Sometimes whenever we see steep corneas, we may think that this steepness is because of keratoconus development. However, if we can see that the epithelium is very homogeneous in the center, this is just a normal steep cornea. And this is another example of normal steep cornea. The epithelium is even thick in the superior part of the cornea. This is the contour effect, which usually makes confusion with the doctors when they see this pattern, and they think that this is post-LASIK ectasia. This patient had myopic ablation, and because of the hotspot in the inferior part of the cornea, the doctors may think that this is ectasia. Actually, this is not ectasia. This is decentered optical zone. It is decentered superiorly, and the computer will understand that the edge of this zone as if it is an elevated area. This is called the contour effect. Now we can differentiate this pattern from the ectasia just by the epithelium. The epithelium is homogeneous and there is no thinning over this hotspot. So that means it is just a decentered optical zone. This is contact lens effect. This is a hotspot on the anterior curvature map associated with thickening of the epithelium rather than thinning. So this is because of the contact lens. We come second to the risk factors, how to exclude the risk factors. I'm going to skip this, and I'd like to invite you to attend this session, the full session that I'm going to do tonight at 9:30. So almost after 2 hours from now. And I will talk in detail about the risk factors and about the algorithm I put, the PS3 algorithm I put for the Pentacam, for the Cyrus and MS39, and for Galilei. And this is the references that I based the algorithm on. We come to the astigmatism. Astigmatism is very important to be studied in order to compare it with the subjective astigmatism in case we would like to treat astigmatism by the laser-based refractive surgery. For example, if the topographical astigmatism is -3, while we want to treat, or the manifest astigmatism is -2. So if we treat the topographical astigmatism, we are going to overcorrect. And if we treat the manifest astigmatism, we are going to undercorrect. Now, sometimes we may flip the axis from with the rule astigmatism to against the rule astigmatism because of this disparity. And this will induce high order aberrations. So there are 9 probabilities that we have to go through, but not in this lecture, of course, in order to to know how to manage this disparity. The second thing is planning the treatment. Third, IOL calculation for the IOL selection. Of course, we have to compare the total corneal refractive power. We shouldn't depend on the simulated K or the astigmatism on the anterior corneal surface. We have to look at the total corneal refractive power display, and we compare it then with the manifest astigmatism. Of course, posterior astigmatism, if not taken into consideration in IOL calculations, then if we are implanting toric IOLs, then there will be an overcorrection if the astigmatism is with the rule astigmatism, or undercorrection if it is against the rule astigmatism. So posterior astigmatism should be taken into consideration. IOL selection, of course, if the patient has more than 0.75 diopters of real astigmatism on the total corneal refractive power, then of course toric lens should be implanted. In addition, if we are planning for premium IOLs and the patient has more than 0.75 diopters and we don't implant a premium toric lens, then the patient will suffer from dysphotopsia. So taking the astigmatism into consideration is not important for toric IOLs only, but for the premium IOLs as well. I mean the trifocal and the EDOF. Then we come to angle kappa. Angle kappa is very important to be taken into consideration in order to centrate the laser profile with the visual axis rather than the pupil center, because as we know that the laser machine detects the pupil, and the laser profile will be applied based on the pupil rather than the visual axis unless we do a shift. Now, if we are treating myopia, we are covering the whole area, so it wouldn't be a problem. But if we are treating hypermetropia, if we don't centrate it with the visual axis, then we are going to induce coma. The same can be said if we are treating astigmatism. In addition, the angle kappa should be taken into consideration when we implant premium IOLs, because usually when we put the lens, it centrates itself within the bag. So it doesn't respect, the lens doesn't respect the visual axis, doesn't respect the pupil axis. It respects the geometrical center of the bag, the capsular bag. So that if the angle kappa is very large, more than 400 microns, and we put the lens, even if we try during the operation to centrate it with the Purkinje, it will not respect this, and the patient will suffer from dysphotopsia, which is a very main reason of lens extraction later because of the disabling dysphotopsia. Yeah, that's it. And then the evaluation of angle kappa can be by the Placido disc devices, or if we are using the pentacam doesn't use the Placidos, then we have to depend on Cordimu in the holiday report. Or if we don't have the holiday report in the pentacam, then we very roughly can depend on the pupil center coordinates. This is the Cordimu given by the holiday report. As you see, this is more than 400 microns, so it is a contraindication for premium IOLs in such case. The pupil center coordinates, we just look at the pupil center X and Y, and then we take half of the X and half of the Y, and we respect, of course, the algebraic sign. If it is more than 400 microns, then, of course, it is contraindication. But this is very rough estimation, and I would advise to depend on the real measurement of the angle kappa. White-to-white diameter is given by the corneal tomography. However, it is better given by optical devices. Why white-to-white is very important? Because in phakic IOL, white-to-white, or in modern tomographers such as the MS39, it gives us scleral spar to scleral spar. It gives us better sizing of the phakic IOL in order to maintain a vault, to avoid cataract and to avoid glaucoma. In addition, the white-to-white is very important even in LASIK when we want to create a flap, because usually if we are using the microkeratome, we are using the ring size based on the K readings. And if the cornea is small, then we may end up with cutting the limbus and bleeding. In addition, if we are planning for the centration of the laser profile, as I mentioned before, in order to avoid induction of the coma, we have to we are moving the or recentering the laser profile, but at the same time we have to recenter the flap creation, because if we want to create the flap, usually we apply the section, whether it is by the microkeratome or by the femtosecond. We apply it usually symmetrically according to the limbus, but this is wrong if we are doing the recentration of the laser profile, because if we cut the flap in the usual manner, then there will be like ablation on the hinge and the ablation out of the bed, which will induce irregular astigmatism and will induce epithelial ingrowth in the future. So this is why we need to recenter the flap. Now, when we recenter the flap as well, if the cornea is very small, then we are going to interfere with the limbus. In addition, we have to avoid complications in the femtosmile, because as we know that in femtosmile, we are creating a pocket. Now, if the angle kappa is within the normal range, then this pocket, the whole pocket, will be within the cornea. If the angle kappa is relatively high, then we are approaching the limbus. And if it is very abnormal, we are cutting the limbus. And in this case, the dissection will be very difficult, and of course, there will be some complications. This is why white-to-white is very important in all types of refractive surgery, not only for lens implantation. Of course, there are some definitions of the white-to-white, like horizontal visible iris diameter and so on. Actually, there is a difference, because the horizontal visible iris diameter is the one that's visible through the limbus, but it is not the real white-to-white. So we have to take this into consideration. White-to-white is given by the pentacam as well. But however, I always advise that to be taken by the optical devices rather than measuring it manually by the caliper or by corneal tomography. We come to pupil size and shift. It's very important to measure the pupil size in the scotopic, photopic, and mesopic, in addition to dynamic. Why dynamic is very important? Because the dynamic will give us the range that the pupil center has changed or moved during the dynamic. Now, if it is within 0.1 to 0.2 millimeters, that's okay. But if it is larger than this, then there will be a shift in the pupil between the scotopic and photopic. And if we are putting a premium IOL, then this may cause dysphotopsia at night, because the pupil center shifts. Finally, I come to the corneal wavefront given by the corneal tomography. Corneal wavefront is very important, not only for the laser-based refractive surgery, but corneal-based refractive surgery, lens-based refractive surgery, and cataract as well, especially if we are planning for premium IOLs. Usually, we study the RMS of the high-order aberrations. The good thing in the pentacam is that we can select the high-order aberrations that I want to check the amount of the RMS. So as you see, in the third row, the N3, I click the N3 because it is the vertical and horizontal comma and vertical and horizontal trefoil. And then I click only on N4 M0, which is the spherical aberration. So only 5 aberrations, and then the RMS is given of these selected high-order aberrations, which is here 0.405, rather than studying the whole amount of high-order aberrations, because the whole amount is not important and not significant, but it affects if we take all of that into consideration. So when we study the high-order aberrations, this explains the patient's symptom. Maybe the patient is suffering from halos, glare, or something. we can select between optimized and customized laser vision correction because whenever there is high order aberrations, it means that, and of course, more than 85% of high order aberrations are of corneal origin. It means that there are corneal irregularities. So we may go for topography guided treatment in order to regularize the cornea, or wavefront guided treatment, which is a topography guided treatment, of course, by this machine, the Schwind. In addition, we can select between spheric and aspheric IOLs because in case of high order aberrations, it's better not to implant a negative or positive aspheric, it's better to avoid changing the spherical aberrations. So in this case, we can select an aspheric zero spherical aberration IOL in this case, because our corneas are inducing high order aberrations or spherical aberrations between 0 and plus 0.35. So I developed as well an algorithm, which is the PSIS. I'm going to talk about it later in this session tonight, depending on the high order aberrations and the spherical aberration, how to select the IOL based on what we have. For the premium IOL, if the RMS is more than 0.5 diopters, then we cannot go for the premium IOLs.
What's the comma?
Sorry?
What about the comma, Mazen?
If the high order aberrations...
0.5, and you didn't mention the comma. What will be the comma in this 0.5?
Usually, if the high order aberrations altogether, okay, including the comma, is more than 0.5 diopters, I don't implant premium IOL.
Yeah, but
regardless, it is induced by the spherical aberration or it is induced by the comma, regardless of that.
So what's the maximum comma that you accept?
I don't study the comma individually. I study the 5 together. If the high order aberrations of these 5 is more than 0.5 diopters, or more than 0.35 microns, then I don't implant premium IOL.
Okay.
Now,
as a summary,
because this is the last slide. The causes of the failure after premium IOL implantation is the ocular surface disease, dry eye, abnormal mesopic pupil if it is less than 2 millimeter or more than 6 millimeter, large angle kappa if it is more than 0.5 millimeter, irregular corneal astigmatism, and large corneal high order aberrations. And thank you very much.
Great, thanks, Dr. Mazen. It was an excellent, comprehensive lecture for this hard and complicated topics. Now, I will start asking all the coordinators and the panelists if there is any question for Dr. Mazen, Dr. Hussam Al-Hassani, Dr. Grimm. Any question to Dr. You don't have Dr. Rahid. Any question to Dr. Osama? To Dr. Mazen?
No, thank you.
Okay. So, Dr. Mazen, there is a few things I didn't want to interrupt you, but I tried to maximize my brain to memorize what you said. So, you mentioned a few things about the total corneal power in treating astigmatism in refractive surgery. So, here we are. You are using the total corneal power in treating the astigmatism when you are doing a refractive surgery?
Yes, I do.
Okay. So just, I know that you do. I need you to highlight this point because it's a very important point for the others. So how you are dealing with against the rule and with the rule when you are treating. You mentioned one example that the subjective was less than the objective, than the measured. And let us say measured is the topography and subjective is a subjective seen by the patient. So patient have -2 on subjective and -3 on the topography. And in reverse, patient have -3 in subjective and -2 in topography. So please.
Okay, thank you very much. Now, actually, there are 9 probabilities.
Yeah.
9 probabilities of this method. Okay. Let me brief it in general. There are general rules to control how we treat when there is disparity. Disparity means disparity in access or disparity in power between the topographical astigmatism and the subjective astigmatism. So in general, we treat the subjective astigmatism, okay, in general. Now, if there is a disparity, we have to take care not to flip the axis on the cornea. If it was with the rule astigmatism and we overcorrect, then with the rule astigmatism on the cornea will be against the rule astigmatism. If we induce against the rule astigmatism on the level of the cornea, the patient will suffer from secondary astigmatic high order aberrations. Although maybe his visual acuity is 20/20, but he will suffer from high order aberrations. It is not a matter of low order aberrations because the low order aberrations has been treated, okay, by the astigmatism. So one example, if both are 180 minus 180, it means with the rule astigmatism, the topographical astigmatism is -3, the subjective astigmatism is -2. If we treat the -2, we are on the safe side because we are treating what is less than the corneal astigmatism, and we are keeping the corneal astigmatism with the rule. Now, if the opposite, in case of the opposite, if the corneal is -2 at 180, the subjective is -3 at 180. If we treat the -3, then we are going to induce one diopter of against the rule on the level of the cornea. Although the patient is fine, 20/20, unaided, but he will suffer from secondary astigmatic high order aberrations because of the level of the cornea. In this case, what I do, I try to manipulate the amount of the astigmatism and play with the spherical equivalent. So I may reduce the amount of astigmatic correction and increase and try to compensate by the spherical equivalent in order to keep the same spherical equivalent that will be treated, but reducing the difference between the corneal astigmatism and subjective astigmatism. I hope it's clear. And we can, of course, give many other examples when they are against the rule, both together against the rule, and in the rare cases where they are oblique axis. But however, there is no time for that.
Okay. Now, any comment from Professor Rahit?
I have a question, Dr. Mazam. I mean, it's still in presentation like always. It's not a comment. It's more like I'm trying to play a devil's advocate here.
No, Dr. Rahid, just I need to clarify that we are still on this subject because of the importance of this subject. So I just need you.
Basically, what I wanted to ask him is, he did mention about the coma being more than 0.4 or more 0.5, you would not consider the surgery. But if what I want to ask you is, from an optical point of view, having a small amount of coma, say vertical coma in this patient, and if you're putting one of your non-multifocal lenses, don't you think it's going to give him that extra depth of focus?
Yes, exactly.
Yeah, for the coma to give depth of focus?
Yes. The coma, when it is vertical, it will give more depth of focus when it is especially vertical. Now, if we consider that the vertical is a vertical and the amount of it and the axis of it is a vertical, so it will give more depth of focus. Now, the question of Rahit is very clear because I didn't want to increase the discussion related to this point, Mazen, but when you have a coma in a part of the high order patients, the axis of this coma is very important. That's what Rahit he need to mention. So the axis, not the amount. Now, that's right. That's why I return back to ask you, what's the maximum coma that you are treating? You said that, no, I will go through the total high order range. I agree with you totally, but the axis of the coma, when we are dealing with any of the refractive surgery, whether for distance or near, axis of coma is very important to consider when we are dealing with it. So when we have, for example, a vertical comma and it's around 0.35 or 0.5, well, I will be happy to implant a diffractive. Definitely, I don't need to pass my opinion, my experience, but I think that Rahit is agree with me for that, because he that will give extend the depth of focus. Now, apart from this question, I will return back to my question, and I will tell you things to attend the session that I will presented it in a customized ablation, how we are prevent overcorrection and undercorrection. One of the issues in the astigmatism that Alcon company, I don't have any financial interest in them, they present a simple way how to deal with the disparity, as you mentioned, between subjective and the topography, and they consider that we need to follow the topography. Now, you mentioned a very important point that it's not the following which one. No, it's to measure that we don't need to be overcorrected with the rule against the rule. That's the main important point that we need to add. Second issue is that if you will follow the protocol of the Alcon, you will see that when you have subjective more than the topography, they will see the difference. They will go to the topography and they will take the difference, divide it by 2, and add it to the sphere. So as you said, you will play with the sphere, but they need to make an equation, and this equation to be followed by the surgeons in a simple way. So I will highlight it. And I'm following it. In addition to that, I'm doing something to use the total corneal power. Now, if the opposite side, they will take again the topography, but if the subjective is less than the objective than the topography, then they will take the topography and they will see the difference and they will divide it by 4. And the result, they will subtract it from the sphere. So they will keep spherical equivalent as it. But at the end, if you will see the consumption of the tissue in between 2, it will be different. And you will save the topographic. So you will treat the topographic, considering that against the rule, I will treat more and I will add according to the total, or I will use the total corneal power, and against the rule, with the rule, I will be less treating. Definitely, total corneal power will give you much information for this. That's my comment. I'm very sorry that we cannot continue discussing, so I will go through and ask our colleague, Dr. Imad Alilo. He's here, I think, right?
But just a second, because I'm still not convinced about the vertical comma. If it is high, that we can implant premium IOLs. Of course, I respect your experience. I respect all panelist experience, but I need to have like evidence-based. If you have any studies, please provide me with this, that the premium lens were implanted with high comma and the patient didn't suffer from dysphotopsia. This is very important.
Here we need to define what's the high comma. The high comma that
vertical. The vertical.
Yeah, it's a part of the 0.5, but it's caused the majority of it. Anyway, I'm asking Dr.
Just a second. So you are with me that the total high order aberrations should not exceed 0.5?
Yes, I'm with you. But here we are considering if the vertical comma a part of it and the axis of this comma, then I will accept that. For example, I will go through a 0.6 or point something if the majority of this total high order aberrations is considered as a part of the comma. Means that this comma contain or create this majority of high order aberrations. See?
So if the high order aberration is 0.7, and most of it is comma, you implant
according to the axis of this comma. If it is
vertical, and the high order aberration is 0.7,
yes,
you implant premium lens.
What's the comma power here? 0.3, 0.35, 0.5.
Whatever.
Yeah,
if it
here,
is 0.5.
Here the comma, it will be around 0.35. We need to consider the others. The spherical abrasion also, it's an important part of the halos of the post-op. So when we are saying that the vertical comma, we need to consider it. That means that we are allowing ourselves to implant a diffractive when the vertical comma, for example, for me personally, is 0.3 or even to 0.4. That's the issue, but not more than this.
Okay, thank you very much. If you can provide me later with some papers supporting this, please.
We will. I'm again asking Dr. Imad Alilo.
Yes, Dr. Safwan, I'm just waiting to finish.
Dr. Imad Alilo, he will talk about an important subject here, biomechanics of the cornea in refractive surgery. So, Dr. Imad, please.
I'm going to share my screen now.
Yeah, please. We are still not seeing any sharing. No, you need to click on the green button. Yes, the green button has shared screen. Just click on it, and then there will be boxes. One of the boxes is your. Did you put your presentation on the screen?
Yes, it's on the screen.
Open it. Okay, and click on share.
Desktop one, whiteboard, iPhone, iPad. This is Finder.
Doctor, did you open your presentation?
So I am not happy.
Yes,
yeah, I asked him whether he opened or not.
So I'm not happy.
So please, when you open your share screen, it should appear to you in the choices, correct? Just click on it.
Just 1 minute.
There is a sound. There is sound coming from one of the speakers. Please let other speaker be mute in a way that we will not hear the other side sounds, please.
Is it shared now?
You need time? No, it's not shared. Ahmad, if you need time, we will skip to the other speaker.
Okay. Okay, I will try to sort out this technical error and come back to you.
Dr. Arthur is here.
I think he left a message that he's going to do something and come back.
Okay. So let us go to Dr. Osama Jalidi as far as that he left his guest and he came back. And we will look at the presentation of Dr. Osama, ocular surface assessment in diagnostic technique in refractive surgery. And let us start with the Osama, and then we will return back to our speakers. Please, Dr. Osama.
Thank you very much. I'll try to.
And please, for the other speakers, let everyone prepare his presentation on the desktop and in a way that it will be ready for sharing.
Can you see it now, my screen?
Well, we are seeing just a schedule. I think that you need to go to open it because you didn't open the screen. It's not open, Dr. Osama. You need to click on this desktop, Osama.
I did, yeah. I'll put it again. How's it now?
Yes, now it's on.
Hi, good evening, everyone, and thank you for the invitation. So basically, I'm going to talk about ocular surface assessment for laser vision correction. So basically, as you know, laser vision correction is different modality, surface laser, LASIK, or SMILE, all of them to correcting refractive error, myopia, hyperopia, or astigmatism, and all of them really need to have very good assessment for ocular surface. Because the ocular surface, as you know, is the most important refractive surface of the eye. It influences the keratometry, the refraction, and also high-order aberration. So it's very important to have very good, healthy ocular surface to have very consistent result. That will contribute to post-operative comfortable for the patient and also the vision quality. So anyone coming for surgery, it needs to be assessed, and if there's any ocular surface problem, need to be treated according. So the prevalence, as you know, for dry eye is very common, and Europe are like about 15 to 20%. Middle East is slightly worse, a bit higher. The women level is about twice. And one thing, as you know, women tends to come more for laser vision correction, so there's more chance to have a dry eye. And other things really, contact lens. Contact lens is a risk factor for dry eye, and also many patients coming for laser surgery, they have dry eye and contact lens intolerance. That's why they come first for laser surgery. So it's very important to screen them, really, especially patients who come and say, I cannot tolerate contact lens anymore. As you know, the dry is a vicious cycle, and this tear film instability causes hypersmolarity, apoptosis, and inflammation creating another instability and the vicious cycle. And same things also with the meibomian gland dysfunction. So it's very important to treat dry eye to prevent this vicious cycle. And patient, when they come to you for the clinic, usually ask about the history. Does he have the complaint of dry eye, dryness, burning, gritting sensation? That's all different symptoms of dry eye. Redness, patient could be even complain of watery eye, reflex secretion. And most of people who have dry eye, they have fluctuating vision. They feel tired and sensitive to light. Ocular surface in general is very important to have balance between all parts of the ocular surface, from the lid, blinking of the patient, should be healthy lacrimal gland, conjunctiva. Corneal sensation is very crucial for tear production, stability of tear film, and corneal surface. All together, it will be important to have a perfect ocular surface. But as you know, the ocular surface is very vulnerable to the assault of our environment, especially here with air condition. So when you patient come for laser surgery, you need to ask him about dry symptoms. When he had the symptom, does he have the dry eye with contact lens? Does he have also dry mouth? You could possibility of Sjogren syndrome. Observe when you examine the patient, does he do normal blinking or not? Ask him about artificial tear. Does he use artificial tear? Does he use a preservative with it? Also the medication. Some medication can cause more dry, like antidepressant. Roaccutane really is very common here. We found that many patients are using Roaccutane, and be careful about this patient. It's very important to ask about that. And also at the end of the assessment, usually we give the patient questionnaire, will help us to decide about his level of dry eye. I usually using ocular surface index, but there's too many questionnaire. It helps you to give it to the patient before final assessment, just will help you and to monitor. When you do patient, we do always corneal topography, and really corneal topography, sometimes that's a very good way also to assess a dry eye patient. You'll find there's the quality of the test is not clear, the rings is distorted, like this patient had the ring distorted after treatment with dry eye, and the right side, the screen, the cornea become more, circle is very clear. And also if you repeat the topography, you'll find if there's too many variation between the two topography, that's a sign of dry eye. Always we're using to assess tear breakup time, so it's very simple to put just fluorescent drops and to assess the breakup time. Nowadays, we could use what we call non-invasive breakup time. It's slightly more expensive because we need the machine, but it's more reliable. There's no consultant variation. Or you could use infilometry, lipoflow to assess the tear film itself. The other tests we usually do in normal clinic, we use the fluorescent drops to see if there's any staining. But the problem with the fluorescent stain is mainly stain the cornea, not as much in the conjunctiva. It's much better to use Lesamine or Rose Bengal to assess the dry eye, because that will see better the devitalized the epithelium cell, and especially with the conjunctiva, you could see better. But the problem with Rose Bengal, it stings a little bit. A Schirmer test is very easy to perform, but really is not very reliable. So it can give you a wrong message about how much dryness for the patient. The new test, osmolarity, is a very good way to assess if this patient had dry eye. You look into the level of the osmolarity of the tear film, and very important to compare both eyes. If like 8 different between the two eyes, that's a sign of a dry eye. MMB9, now many people start using MMB9 as detected for inflammation. It's increases for all ocular surface disease, and they have very strong relationship with the dry eye in terms of survey for dry eye, fluorescent stain, or tear breakup time. It's very simple test, and that's, as you know, MMB9 is inflammatory marker. So if there's any inflammation in ocular surface, it will be raised. The test is very simple, done in outpatient clinic. But the problem with the test is you do it fast, simple, but it doesn't give you the quantity of the inflammation, but also doesn't give you the cause. The other modality you could use corneal tomography, which can help the tear breakup time. It will also can assess the tear meniscus height, and the newer one also incorporated what you call mammogram, which you can use infrared photography to see the meibomian glands, the blockage, and the function of the meibomian gland, which is very important and is a big factor for dry eye. Conclusion is important to have good ocular surface assessment before laser vision correction. Many new tests available to assess, but really the most important is clinical examination of patient, examine the patient carefully, and the history. That's you can know very help, but the test can help you, but it's not the main things. As you know, we should avoid laser vision correction if someone had moderate or severe dry eye. Mild dry eye, if you treat it and it's controlled, then you could go ahead with laser surgery. Dry eye is very common also to happen after laser surgery. So especially if you do LASIK, there's more chance to have dry eye more than smile, and that smile more than BRK as a risk of dry eye. But the good thing is that the majority of this dry is improving, but sometimes take a few months up to a year to go back to normal, although very rarely people could have long-term dry eye. And thank you very much.
Great, thanks, Dr. Osama, to be on the time. And we will ask the panelists and the speakers if there's any comment or any question to any of the speakers. Dr. Osama Al-Hassani, Dr. Rahid, Dr. Mazen, any question to Dr. Osama? Osama, the lady? Any comment? So here we will, and there is a few questions in my mind to start with, and we are still talking about the importance of our diagnostic tools to select the proper patient for targets that we need to reach. So from this point of view, until Dr. Imad prepare his presentation, I'm seeing that he's doing very well, and he's present his share his screen. I need to ask that I think that we have Osama Al-Hassani here doing lenticular extraction, and Dr. Rahid, I think that he's doing lenticular extraction. I think that Imad is start too, but I hope that I'm not wrong. So what's the higher aberrations can play a role in your practice? Let us start with Osama Al-Hassani. You are doing Osama Al-Hassani with us?
Yes, with you.
You are doing a lenticular extraction, and I think that higher aberrations in your site, it play a role in your selection for a patient for a lenticular extraction. Definitely, Professor Mazen, he show us the great things related to size and location and centration, and how the decentration related to the angle of kappa or visual axis. It's so important, and that we will come to it with our discussion later on in this meeting, how the importance and advances with a lenticular extraction. But precisely, what's the importance of higher aberrations for those that they are doing a lenticular extraction? Dr. Osama, you need to unmute your site. It's a mute.
Sorry. Okay. Now you hear?
Yeah. Yes, I'm hearing.
Okay. Yes. For the higher order aberration, if it is more than 0.5 diopter or more than 0.35 micrometer, we have in our assessment this high order aberration, because smile surgery or even optimized LASIK may increase these order aberrations. That's why we need to know these order aberrations is treatable, like Dr. Osama Jaledi said. If it is due to dry eye, okay, we treat it and then we do our surgery. But if it's not treatable, we should go to other type of surgery, like customized treatment, because these surgeries, lenticle extraction, also increase the high order aberration, especially the spherical aberration and coma.
Now, here I can remember one presentation in the last ISCRS. The presenter presents few things related to that post-lenticular extraction. He found an island in the center, and he was asking himself, I think that Rahit, he was with us, or I don't remember. He was asking himself why this central island present in the center of the map post-op or post-lenticular. So I asked him one question: is that did you investigate this patient for a pre-operative or induced pre-existing higher aberrations? The answer is absolutely no. So for those that they have a higher aberration pre-existing, yes, and we are not finding them or not investigate them and not excluding them, as you said, it's very important for even for those that they are doing a smile or a lenticular extraction. It's very important to select and exclude those patients that having above than 0.5. For Dr. Mazen, if he's still with us, Dr. Mazen, you are still with us?
Safwan, can we start, because we are...
Yeah, I'm just, just give me 1 minute. Just I need to ask Dr. Mazen one question. You mentioned things about the visual axis and the lenticular extraction. How you think, in your opinion, we can correct the centration related to the visual axis?
During smile?
Yes, in smile, considering that we are not treating hyperop. So we are not treating those that they have high kappa.
Okay, so your question, because your internet was unstable, so the question was how we center the smile, yes, with the visual axis.
Yes.
Okay, it's very easy, because we ask the patient to look at the blinking light, and then we mark it by a marker, which is the Purkinje reflex. Then I center the suction with this target, with the mark that I did. So and that's it.
Okay.
Very easy.
Dr. Safwan, there is very important feature in the smile, that the patient using his own eye muscles to put it on that curved cone. So the anatomic shape of the cone plus the ability of the patient to focus on that target, he will guide us exactly to the right centration on his visual axis. Okay. But you have to be a little bit gentle and very careful, and you can you does not have to be go with the centration only on the center of the pupil. This is not the right way to do it. The right way is to allow the patient to use his ocular muscle to guide you directly to the visual axis.
Do you think that we are not in need to do or to improve the static track system in this machine?
Well, I do believe that in the next generation, iris registration will be there, and it will be quite useful tool, especially when we are treating astigmatism. And also from my experience in smile, smile is a little bit of
I was right? So I was right.
It is less inducing to high order aberration than LASIK. This is evidence-based with so many studies. And second thing, it's a little bit forgiving.
So
the optical zoom is 6.5.
Static track system for smile is one of the important issues that we will start. Ending with this discussion, we will let us start with your presentation, and we will say how you will present to us. What's the importance of biomechanics indices in refractive surgery?
Thank you, Dr. Safwan. Tonight, I'm trying to, first I would say good evening for all of our colleagues who is following us. Because of our audience, the majority are general ophthalmologists or interested in refractive surgery, I'm gonna focus on the clinical application of these new indices with a quick idea about the theoretical part. So I will start by asking everyone here, who will operate on such an eye? This is quite a clear-cut case. You doesn't have to think about it. And on the other side, when you have such a good cornea, also you won't think too much. But how about these cases when you see some a little bit of warning signs are there, some abnormality on the posterior curvature or on the anterior curvature, and this is one case. The other eye of the same case, you also even see more warning signs on the pentacam. And if we had this case also, we can see that it is quite suspicious. So we need something a tool to make our screening and our decision-making process more sensible. And it took a long way to develop such a tool, which now ready in our hands to guide us how to make the decision in this case. It's started with the new concept introduced by Cynthia Roberts, that theory, which is published. She published a paper that the cornea is not a piece of paper, plastic. That theory assumed that initiating an event of ectasia could be a focal reduction in the biomechanics or in the elastic biomechanics of the cornea. This will result in thinning in the weaker area because it's strained more than the surrounding stronger area. And the focal reduction in the elastic modules generates a greater deformation for the same load. So here was the beginning of the introduction of the biomechanics and the elastic character of the cornea in determining its susceptibility to ectasia later on. So now we are having better understanding of the cornea. It starts by a normal healthy cornea. Then there is some change in the elastic modules. Then the level of biomechanical keratoconus. This is a this cornea has a susceptibility to do ectasia, but it is not yet clear. Then the tomographic topographic keratoconus, and finally the late stage when it's manifest on slit lamp. So the biomechanics, bare definition, it depending on the material and the geometry. So both has to come together to give us this concept, and we need a tool to study these characteristics. That's why they developed the Curvis ST. Curvis ST is an ultra high-speed Scheimpflug technology, which is making 4,330 frames per second. It depending in non-contact tonometer, which is symmetrically metered air pulse, captures around 140 images in 31 milliseconds after air pulse, and doing this with a scope of 8 millimeter horizontal coverage. This amazing tool can give us valuable information, whether it's about corrected IOP, accurate measurement of CCT, and the most important things is the information about biomechanical properties. So it was a long journey when they started to use it for measuring only corrected IOP, but because there was a collaboration of a group of doctors in different continents, they collected a huge amount, thousands of cases of data, and they developed the normality value first. What is the normative data for this machine? And then by implementing the artificial intelligence, corneal biomechanics index came, then developed to total biomechanics index, and finally the stress strain linked index and post CXL. So this is, I'm gonna show you now how it looks like in the real life practice. We will see now how is the curves showing in two cases. One of them are keratoconus and one of them are quite normal. No, sorry. I don't, yeah. It looks like there is something happened in this video. Can you see it moving? Can you hear me, sir? Dr. Safwan, you hear me?
No, it's not functioning.
It's like, I'm with you. I'm with you. No,
Okay,
I'm not
fine.
seeing the video.
We will skip
I'm not
that.
seeing the video. Yeah, the video. Usually, I saw it before, so I'm not seeing it. Anyway.
Right, no problem. So the new corneal biomechanics index, depending on studying some features or characteristics of this wave done by Vinciguerra. So that's why it came as a Vinciguerra report. And it gives an gradation from 0 to 1.0. And the other new index is total biomechanical index. It's depending on conjunction the raw information from the BAD-D, the corneal topography, and the biomechanical index in one much more mature index called total biomechanics index. Yeah. And the normality is, if it is less than 0.3, that's normal. Between 0.3 to 0.5, this is a moderate risk. More than 0.5, it's high risk. And you can see how it's beautifully illustrated by colors. So how we can use this concept, these new tools in decision making in our cases. This is the first case. You can see the topography, the suspicious topography in the right eye, while when you do the Corvus test for that, or the biomechanical test, the TBI in this case is 0.06. So it is safe to proceed for laser vision correction. Of course, it doesn't tell us what kind of procedure it has to do. Is depending on the standard consideration from the amount of the refractive error, the corneal thickness, the residual stromal level. So all of this consideration, we take it in consideration to decide which kind of procedure we are doing, LASIK, PRK, or SMILE. But at least it gives us the green light whether this cornea is safe to cut or not. If we look to the other eye.
Comment here, the Bell and Ambrosio, you have any comparison with the Bell and Ambrosio?
Yes, sir.
Yeah, please. That's the issue that is very important to know.
What you mean by comparison with the Bell and Ambrosio?
Means that I need to see the Bell and Ambrosio screening and the BAD.
Yes, the Bell and Ambrosio is there in the first. Sorry,
yeah.
Just 1 minute. It is there in the first slides I show you. I can go back to it later on, Dr. Safwan.
Yeah, yeah. Okay.
So in this case, if we look to the other eye, it's also show us that the TPI is 0.06. So it is safe to cut even in this suspicious corneal topography. If we go to the other eye, on the other hand, we can see that this cornea has very bad biomechanics, that the CBI is 0.1. So now our way of thinking has been changed from thinking of doing laser vision correction to consider it as form of frost keratoconus. Now the new concept is not form of frost keratoconus, it is a cornea susceptible to ectasia. So this is need to be monitored, and we might consider cross-thinking in case of improvement or in case of deterioration of this cornea. So even the other eye, it's the same. So this gives us the credibility of these kind of techniques. So if we look to this cornea, Dr. Safwan, what do you think about it? This is your Bell and Ambrosio, and everything is here.
Yeah. So that's I asked you that because I know I'm using the issues, and I know you that I need you to highlight that because it's very important. The Bell and Ambrosio here normal, and then I need to show you the BAD how it shows, or the Corvus how it shows.
Yeah, that's why I presented this case also. You can see it at that normal Bell and Ambrosio, totally normal cornea. But when we do the Corvus, it is really a high risk case.
Yeah, TBI is 0.6.
Yes, TBI is 0.6, and how we validate our measurement by looking to the other eye.
Yes, you
will see a frank advanced keratoconus. So this kind of cases give us a credibility to this tool, and make us more and more depending on its result in the suspicious cases.
Exactly.
So,
I will interrupt you because it's very important talk. Here, we will go back to Rohit, what he said. Family history is very important because you might have both eye within normal limit.
yes,
and
but
that's
biomechanics, when it is suspicious, we start to dig deep and find what other factors that might be there.
So here it will raise another question and another question that we need to go back.
Can you just finish this last chapter, and then we can go for discussions? Now, the new development in the biomechanics has came recently, I think last year. In the ESCRS, they were released the new CPI-LV. This is a new normative data, has been developed by the same groups of doctors from 3 or 4 continents, including gathering information from around 4,000 to 5,000 patients. And they try to put a normative data for post-laser vision correction. And this is very important because previously the software does not have such an ability to evaluate the corneal biomechanics in non-naive eyes. So whenever you have a corneal surgery, the old software was saying that it is bad TBI. Now we have a new step forward by having this software. Now this software will ask you before you proceed whether this patient has, if you know, of course, this information, you have to manually introduce whether this patient have PRK, LASIK, SMILE, or refractive surgery of unknown, which kind, if you don't know what kind of refractive procedure who had, or you don't know whether he has refractive procedure at all. And then it will give you a new biomechanical indices depending on this input. This is very important in detecting the early progression of ectasia. The most important usage is if you have a regression, but you don't know whether this is an ectasia or just a normal regression. And especially when you need to touch up the cornea, you want to know whether this cornea is strong enough to tolerate your touch up or not. So this case, for example, we have, if you look at that topography, you can easily spot that this has a, after laser vision correction, but still the CPI LV is quite good. So this is a stable keratoconus, stable cornea after laser vision correction. On the other hand, you can see this case when the CPI LV is high, and this is an ectasia case. If you notice that in this new software, when you add that this cornea has a previous refractive surgery, the bad D and the TBI will become in gray because in this case, these are not validated anymore. So this new software automatically put it in gray and eliminate it. And a new graph come, which is the CPI LVC. So to sum up, Corvus is a new tool in our hand, which making the refractive surgery more safe for the patient and less troublesome for the surgeon. The biomechanical indices is useful now in the decision making and even in the follow-up. And biomechanical indices has also another useful indication, like it is gonna, there is some studies will go in using it in glaucoma, corrected IOP, and some other indications as well. So corneal biomechanical indices is here to stay as the old castle of Aleppo. Thank you very much.
Great, thanks, Dr. Imad. It was a very interesting lecture related to interesting subject through, and you know, the Vansiguara, Paulo Vansiguara, we are around with him for a few cases, especially follow-up of post cross-linking treatment.
Actually,
now,
I was in the beginning when they introduced it. I think one of the first machines in the Corvus in UAE was implanted in the hospital I was working with, and I was sending some data to Ambrosio as well, and having his feedback regarding it. So it's really interesting, and it's really useful, and it will become, I do believe it will become a standard in the future.
Well, the issues is that it changed some beliefs that we were saying that an extra is not a tool. I think that even now he's Mazen with us, and he don't believe in an extra. But Corvus shows different rigidity in cornea that's been treated with the crosslink as a general. And now Paulo Vansiguara and Ambrosio, they are working on two things: the type of cross-linking.
Dr. Safwan, we cannot hear you.
Sorry, what you are saying? I didn't get you. Just say it again.
Dr. Safwan, I didn't hear you. Actually, Ricardo Vansiguera has just in the last ESCRS talked about a small study done around the corneal biomechanics after extra, and the statistical analysis said its effect is very minor. It is not significant. It's not going to change. It is not going to change, or you cannot depend on it when you have a real weak biomechanics of the cornea. The lecture is on the cornealbiomechanics.com by Oculus.
Yeah, that's what I'm saying. It's under the study now, and Vansiguara is concentrated on the types of the cross-linking that's being treated for the cornea, and which type, and accordingly he's collecting data to say that which one by biomechanics we can say that it's better than the others, something like that. And they are studying also those that they've been treated with an extra, whether laser or a LASIK extra, just to see what's the biomechanical screening can give us addition to the
one of the main finding right now, Dr. Safwan, which is against our thinking or our believe that it was right, that after cross-linking, that stress line that is not really correlated with the effect.
The demarcation line is not
the demarcation line. Yes, it's not that significant.
Exactly. So that's what I'm saying. The biomechanics assessment for what we are getting more information and depend on it, it will change our belief for a lot of issues related to the selection of the patient, which patient safely to go through and do the LASIK or SMILE, as you said, or even the laser, or which patient that we need to go through to do laser and we are safe. And now what we are doing, we are comparing three screening from Cyrus, screening from Pentacam, Bell and Ambrosio, and screening from biomechanics. So and I need to see which one will be more sensitive in detecting those that we consider them as foam frost, but now the definition, as Dr. Mazen said and Dr. Aid, the definition is different, because those having foam frost, mostly they have epithelial changes, and now we are depending on the posterior, not anterior. So,
excuse me, Dr. Safwan, can we interrupt you? Sorry, but we are running behind the time, and still we are having symposium, I told. So we can have Arthur as soon as possible, then we can have the symposium, please. Sorry to interrupt you, but we are running behind the time. We are more than 20 minutes. I'm sorry for that.
Just to summarize.
Can you, Imad, keep it to the end? Sorry, if you don't mind. Let us finish Dr. Arthur, then the seminar. Then if we have a time, we can call. Sorry, I'm sorry.
Because I was asking for Dr. Arthur. He's not here.
He's here, Dr. Arthur, yes.
Okay.
Yes, please go ahead, Dr. Arthur, please, if you don't mind, Dr. Safwan. Because by 9 o'clock sharp, we'll start the other session, and we are already 20 minutes early balance.
All right, thank you, gentlemen. I'm going to speak about visual quality, and I can actually make it happen a bit more quickly. I think I have 20 minutes, but I'll try and do it in a quicker time. So this topic should have been a little bit earlier, but we got caught up a bit with time. So it's just about a visual quality assessment. And generally speaking, on a Snellen chart, we only measure in quantity. The quality includes things like contrast sensitivity, wavefront analysis, ocular scatter, tear film, these differential corneal intraocular high order aberration analysis, and then also the way a patient would sketch their own high order errors. So contrast, we're not going to go into now, we're all aware of contrast, but it's a super important sign of not seeing well. Wavefront analysis, I'll speak a little bit about the wavefront, wavelight wavefront analyzer, a bit about the Osiris, and a bit about the eye trace. I'm going to show a patient to you. This patient, 36 years old, had LASIK many, many years ago for -10. And this patient landed up with needing an enhancement in May 98, but he continued complaining of glare and halos. So I want to show you how much wavefront can help us. Here was his biggest issue. He had glare and halos at night, but a different problem in the day. During the day, he had ghosting. And you sort of find it hard to explain that when you're just doing a refraction. So look at this patient. His pupil's large. He's got very high HRMS, and he has a lot of spherical aberration, C12. And then you'll see as the pupil becomes smaller, you'll see how his aberrations are now almost C12 and C7 equal. And as his pupil is now small and he's in the office working, suddenly the only area he has is coma and the spherical aberration is very small. So these devices are very, very clever to help us understand why someone's symptoms are different in the day than what they might be at night. The tear film analysis is a talk on its own. I won't go through that. And I'll share a couple of pictures of tear film analysis, but that's super important. It's the first surface of the eye that breaks light. Ocular scatter is an important one that I want to spend a little bit of time on. The device we use is the AccuTarget or the HD Analyzer, and it's a device that really helps you see what the patient is seeing. And it helps you often select the best treatment for a broad spectrum of patients. You can use it for laser vision correction, cataract surgery, dry eye, presbyopia correction. So it's got a wide application, both helping you plan what to do up front, but also when you have an unhappy patient, about trying to help you figure out what's happening. So what is ocular scatter? So aberrations impact light distribution on a small angular distance. And aberrations we know a lot about. We've been speaking a lot about it today. Coma, trefoil, tetrafoil, those kinds of things. But scattering is something else. It causes a uniform distribution of light across a wide region of the retina. So conditions in our environment that affect scatter are things like dust, fog, sand, pollution in the air. In the cornea, it's the anterior surface, or the stroma or endothelium. It could be the aqueous, protein and cells in the anterior chamber. It could be early cataracts. It could even be things in the jelly. So if someone sees glare, there's a glare source, and the glare lands up on the back of the eye in a fixed point. If someone sees scatter, what happens now is the light coming in scatters in all directions and impacts a much, much larger area of the retina. So aberrations on the left, this would be a level of coma and some spherical aberration. Scatter is on the right. It won't impact the wavefront. So this shows you very nice. On the left is significant light scatter. On the right is small light scatter. And even though these two wavefronts are exactly the same, the person with low scatter has a much higher contrast and better vision than the person with high scatter. So aberrometry measures the issue at the corneal wavefront. That's where it measures it. It measures either the ingoing ray or the outgoing ray, where scatter measures what's happening on the retina. So it gives you a much better idea of what's happening there. If the scatter is low, you're typically seeing well, there's low scatter. If the scatter is high, you have an early cataract or something else going on that's starting to impact your contrast and your quality. So this is very interesting. When we look at a cataract patient, what we're seeing is we see the cataract and we see the light that comes back at us. That's called backscatter. And we might think there's an early cataract and the patient has no symptoms, and vice versa. So what the patient actually sees is the light that passes through the lens and lands up on the retina. And that's what this device shows us. It shows us what's happening on the retina. Now, most times there's good correlation, and you can see as the cataract increases, so the scatter increases. And this same device can give you an analysis of the tear film. So this tear film is 5 seconds per row. You can see how on occasion the tear film is quite good. Yeah, it's good for a few seconds in a row, but then for another duration of seconds, it's very, very poor. So it gives you a good idea what optical quality is doing. So in summary, this device really helps us see what the patient is seeing and helps us optimize outcomes for all of our patients, cataract and refractive. Now, I spoke about this a little bit earlier today on these devices that have the ability to compare corneal versus intraocular wavefront. And eye trace I spoke a bit about. I'll share something more about that now. The NIDEC OPD3 scan does the same thing, as does the Topcon KR1W. So how does it work? Well, it takes a simultaneous topography and a whole eye wavefront at the same time. It also does a refraction, has the ability to separate these images and really start understanding what's going on. And therefore, it can help us manage post-ophthalmic IOLs, as we saw earlier. Where does it fit in? We would normally do auto-refraction, tomography, topography, wavefront, HD analyzer. If we start seeing our answers aren't making sense, we'll do an eye trace. So we don't do an eye trace on every single patient, but when we need answers. So look at this patient, how much the eye trace helped here. 53 years old, had RK more than 25 years ago, presents now with a reduction in vision, and my colleague diagnosis a posterior subcapsular cataract. Vision still correcting to 2020 and 2030, but the patient's quality vision is poor. So when I saw the patient's file, I said, please bring him back. I want to do an eye trace and see what's going on. What's the problem? Is the bigger problem the small optical zone? Or is it this posterior subcapsular cataract, which might even be a Mittendorf spot? I don't know. So here's the RK, smallish zone, not too badly centered, but very, very flat area on the one side. And the left eye, you can see much more of a decentered ablation. And you see exactly the same thing on Placido disc, decentered on the left eye, especially optical zone. Now we do the eye trace, and it shows us this terrific noise on the cornea, so high that the device tells us you can't really trust what's happening intraocularly because the aberrations are so high on the cornea. And it's repeatable. You do it again and again, and every time it comes up with the same error. So it's not like it's once made a mistake. It's finding this problem consistently. And it finds the same thing on the left eye. Massive aberrations, superiorly, and so this would be coma both vertically and horizontally, and it's consistent. So now we really understand what's going on. So if we were to do a cataract for that patient, they'd be so unhappy with the outcome because they're going to say it made no difference because the problem is lying primarily in the cornea. So we decided to first do a topo-guided PRK to regularize the cornea, and then we'll review the cataract again. Here's another patient. This patient had incisional surgery years ago with AK, and comes in now. Eye trace shows that on the right eye, the cornea is the problem, and on the left eye, internal is the problem. So here's the cornea on the right eye, cornea on the left eye. You can see it's not regular. Same thing with pentacam. And we do the eye trace that says on the right eye, the cornea is more blurry than what the internal optics are. So we decide to go and do a cataract on that eye. And so that's on the left eye, internal is the bigger problem. The cornea is still fine. So we decide to do the cataract on the left eye. We did it 9 months ago. And so the patient comes back now, he's doing well with the first eye, COVID kept her away. And now she comes back ready to do the right eye topo-guided PRK. But I wanted to repeat the eye trace to make sure the condition is still the same. Cornea looks exactly the same, no change in the cornea. And now on a relative scale, the internal optics are worse than the external. 9 months ago, this was different. So this has just made me change my mind. And I'm now going to, instead of doing a topo-guided PRK, I'm going to first go and do the cataract operation. And then we'll do a topo-guided PRK post-operatively as required. So the eye trace really gives one confidence. It gives me more confidence. It gives my patients confidence. It gives me confidence that my patients understand the issues. And it helps, it provides objective data that fits the subjective experience of the patient. And it gives the patient a voice. They sometimes can't tell me exactly what's going on. The eye trace tells us for them. So in my view, the eye trace makes complex optics understandable. And I'm not a consultant for Tracy at all. I don't get paid by them at all. I just love this device. So here's a case complaining of glare with the trifocal implanted 3 weeks ago. The scatter is low. The tear film is very good.
I just need to, I'm sorry to interrupt you, but just we need to summarize because we have a presentation from Lunatus and they need to present their presentation. We don't have time. So
okay.
I'm sorry for that.
I was given 20 minutes for this, but I'll finish it now. But I was given 20 minutes for this talk.
Yes.
It's gone on so long is why I can't give the talk. I can't finish it. But let me finish. I'll just finish with the last slide.
Okay.
That says visual quality is paramount. It's very, very important. There are multiple sources of potential origin. Modern technology today can help us identify those issues. It can help the patient understand the problem. And so today, these technologies are really partners in our practice that help us make the right decisions and get the best results. Thank you very much.
Great, thanks, Dr. Arthur. Always I'm learning new things from your side. Great, thanks for your interest lecture. And I will invite Mina from Lunatus to present the presentation of the Lunatus related to, I think that she's ready. Mina?
Yes, hello.
Yes, yes, Mina. Sorry to make you late. I'm very sorry. Yes, Mina.
Very happy to be here. Thank you very much for the invitation. Good evening, everyone. Today we will briefly introduce to you Artilac Complete, which is our newest addition to the dry eye range that we offer from Bausch Health. Artilac Complete is a complete solution for dry eye disease as it supports the 3 layers of the tear film. Before talking about Artilac Complete, I just want to highlight few facts related to the latest DEWS report. First is about the definition of dry eye being updated as a multifactorial disease, and this takes us to all the components of the ocular system that are involved in dry eye: the main and accessory lacrimal glands, the ocular surface, and the meibomian gland, which result in a 3-dimensional tear film composed of an aqueous component from the lacrimal glands, lipid component from the meibomian gland, and mucus component from the corneal epithelium and the goblet cells. So dry eye is multifactorial because any deficiency in any of those components can result in dryness. We can have goblet cell deficiency, lacrimal gland deficiency, or meibomian gland deficiency. And this takes us to the second highlight from the DEWS report, is that determining whether the major cause of an individual's dry eye disease is predominantly related to aqueous tear deficiency or to evaporative causes or both is critical in helping select the most appropriate management strategy. And that's why they defined a diagnosis algorithm to define whether we have an aqueous deficient dry eye or an evaporative dry eye. And it's important to highlight this difference because aqueous deficient dry eye like Sjogren's syndrome, lacrimal gland deficiency, compared to evaporative dry eye like meibomian oil deficiency or others, both of them has a different predicted natural history. The predicted natural history of aqueous deficient dry eye starts with a decline in the lacrimal flow, while in the evaporative dry eye, the lacrimal flow is maintained, but the main decline comes from the tear film spreading and the integrity of the tear film. And this is where we introduce Artilac Complete because we've always had Artilac Advanced as a support to the lacrimal flow as hyaluronic acid 0.2%. And now we are introducing Artilac Complete to the evaporative dry eye disease patients suffering from meibomian gland deficiency or goblet cell deficiency, where the main goal of treatment is to restore the lost integrity of the tear film. So in both, like, for example, like the indications of Artilac Complete, we have meibomian gland deficiency, where we have a deficiency in the lipid layer, which leads to hyperevaporation, or for example, cataract surgery, where we have a deficiency in the goblet cell density, even after 3 months of cataract surgeries. So another point that we want to highlight from the DEWS before talking about Artilac Complete is the general characteristics of an ideal tear supplement. According to the DEWS report, an ideal tear supplement should be preservative-free and should have a polymeric system to increase its retention on the ocular surface. Preservative-free lubricants allow the patients to administer the lubricants more frequently without the risk of toxicity, and the viscosity agents increase the residence time and provide longer intervals of patient comfort. And hyaluronic acid 0.2% has been described by the DEWS as a lubricant or a viscosity agent that has longer ocular surface residence time compared to 0.3% hydroxypropyl methylcellulose or 1.4% polyvinyl alcohol. And this takes us to Artilac Complete, which is indicated to for the patients who have evaporative dry eye disease like meibomian gland dysfunction or post-cataract patients. Artilac Complete supports all the 3 layers of the tear film, and its design is inspired from the design of the natural tear film. Natural tear film is composed of an aqueous layer, mucin layer to improve bioadhesion, and a lipid layer to reduce evaporation. Also, Artilac Complete is composed of hyaluronic acid 0.24% to support the aqueous layer of the tear film, In addition to carbomer to support the mucin layer to improve the bioadhesion, and glycerol plus medium chain triglycerides to support the lipid layer and reduce evaporation, and also Artilac Complete is preservative-free and buffer-free. Highlighting the key ingredients of Artilac Complete, we have hyaluronic acid, 0.24%, which is the body's own substance, which has very good tolerability. Also, hyaluronic acid has very good water binding capacity to provide superior lubrication and mucoadhesive properties, thanks to the non-Newtonian viscoelastic shear thinning behavior, which gives hyaluronic acid very long ocular surface residence time. We can see here that the ocular surface half-life of HPMC is 39 seconds, polyvinyl alcohol is 44 seconds, hyaluronic acid is 321 seconds. So that's why with 0.2% hyaluronic acid, the tear film breakup time is still prolonged even after 6 hours of a single drop installation. But it's important to choose the optimum concentration of hyaluronic acid, which is provided in both Artilac Advanced and Artilac Complete, which is hyaluronic acid 0.2%. 0.2% is the optimum concentration in terms of lubrication and also in terms of promoting the wound healing, as the maximum effect in speeding up the wound healing was observed with hyaluronic acid 0.2%. Second component of Artilac Complete is carbomer, which supports the mucin layer. As we see with the development of dry eye disease, we develop dry spots due to the tear film deficiencies. Providing a three-dimensional eye lubricant provides support to all the three layers and achieves tear film replenishment and completes the tear film back to normal. And having carbomer in the formula of Artilac Complete improves bioadhesion, which is a key to tear film stability. A carbomer-based lipid-containing artificial tear formulation provides an improved scores of ocular surface staining grades, tear film breakup time, Schirmer values, ocular symptom score in patients with dry eye syndrome compared to natural or normal artificial lubricants. Also, carbomer provides superior efficacy in reducing the symptom score of dryness and improving the tear film breakup time compared to polyvinyl alcohol, and provides better response rates after 4 weeks in the patients who received a carbomer-based lipid-containing artificial lubricant. In conclusion, Artilac Complete provides the support for all the three layers of the tear film. It's targeting the patients who have evaporative type or the evaporative subcategory of dry eye disease, whose main goal of treatment is to restore the lost balance or the lost integrity of the tear film to reduce the evaporation. Artilac Complete is approved by the UAE Ministry of Health, and it's approved with a dose with no limitation, neither on the duration of treatment or the frequency. It can be used as much as the need arises. And in conclusion, Artilac Complete is an addition to Artilac Advanced. Artilac Advanced is hyaluronic acid 0.2% preservative-free, targeting the aqueous deficient dry eye disease like lacrimal gland deficiency, Sjogren's syndromes. And now we have Artilac Complete to support the patients who have evaporative dry eye disease like meibomian gland dysfunction or post-cataract patients. Artilac Complete supports all the three layers of the tear film, and hence comes the name Artilac Complete, because it's a complete support for all the three layers. Thank you very much, and it's a pleasure to be with you on this prestigious panel. Thank you very much.
Great thanks, Mina. I think that here we need to conclude the session. And
Safwan, if you have 2 minutes, Dr. Imad, if you want to just 2 minutes, please, or 1 minute.
I will. I'm in my way to ask Dr. Imad Alilo if there is any question, or you need. You mean Imad Alilo, right?
Yes, he want to comment about something, yeah, before we close.
I'm asking Dr. Muhammad.
Okay.
I'm asking Dr. if there is any comment for Mina or any of the speakers. Dr. Imad, you need to comment, please. Dr. Imad Alilo. He's out, Dr. Muhammad.
Okay, so maybe we can conclude so we can prepare ourselves to the next session. We are already 10-minute balance.
So great thanks for all speakers, and great thanks for panel members, and great thanks for Mina from Lulatus. They are give us the best session, and great thanks to Dr. Muhammad Amri give us this opportunity. And here we conclude. So see you in other sessions.
Thank you for all of you. Thanks a lot. Thank you, Mina, for all speakers. And regarding the participant, we are going to start by 9:15 in the medical retina session, and 9:30 by pediatric and also corneal topography. And we already sent the link if anyone want to attend. Thanks a lot. Appreciate all speakers, Dr. Usama Al-Hassani, Dr. Imad, Dr. Mina, and Dr. Safwan. Very thanks to you. Dr. Millicent, thanks a lot for being with us, Dr. Mazen, and everyone. Dr. Arthur, I don't want to miss anyone. Also, Dr. Rohit, also. Thanks a lot to all of you, and good night.
Thank you so much, Dr. Muhammad.
Thank you.
Thank you.
Thank you.